My name's Richard Hardwick. I'm the Medical Director at Sighted Health. Gavin is going to be giving a talk, Gavin Bryce. He has been involved in the setting up of a service in Wishaw in Lanarkshire and has really developed an extremely effective pathway to get as many patients through the test as possible. And he's kindly come down, all the way driven down last night, to share his experiences with us, and then we'll answer questions at the end. As I say, we are quite time constrained, so he's going to give his talk and then we do some questions and answers. You can put your questions in the app or hold on to them, and there'll be a roaming mic, and we'd be grateful if you could rate the session at the end. So over to you, Gavin. Thank you.
Thank you. So my name's Gavin Bryce. I'm a consultant surgeon based up in University Hospital Wishaw, which is in Lanarkshire. I've also got a role as the Upper GI Cancer Lead for the Managed Clinical Network in the west of Scotland. And so this is something that interests me a great deal, and I've been glad to be a part of. There we go. So the plan here is just for me to very quickly talk about how we set up the service, some of the challenges within that service, and talk a little bit about the pathway that we have. Specifically using capsule sponge in patients who are symptomatic. So we're talking about a different group to Barrett's. This all starts, and I think most people know, when COVID hit and our board took the decision to take down all of endoscopy apart from urgent or emergency endoscopy. That wasn't the case across all of Scotland, but it was for us and a number of other health boards. And we were made aware of through some of our colleagues who had been meeting over a while to talk about Barrett's programmes. We already had a connection between us, that there was something out there which was the capsule sponge. And I'm sure most of you know about this, but this is a small sponge that's enclosed within a plant-based capsule. It's about the size of a multivitamin, so it's easy to swallow. Patients swallow it down, and within 7 minutes, the capsule disappears, and we have a sponge that can then be withdrawn in a piece of string. And what that does is it collects cells 360 degrees from the esophagus. At the point that this happened, endoscopy was taken down, we were made aware of this. There was also the publication of the BSG trial, which hopefully most of you are aware of, which was a randomised controlled trial of cytosponge against just usual GP care, which was GP appointments, PPI, and then maybe a referral in for endoscopy. And the outcome from that was essentially that you could diagnose Barrett's more often in the cytosponge group than in usual care, and with intention to treat, Barrett's esophagus was diagnosed in 20 per 1,000 person years compared to 2 with usual care. And so we felt fairly confident that this was something that was good and safe to bring in at this point. We then decided what the 2 target groups would be, and those were the symptomatic patients, mainly reflux predominant. At the start of this pathway, we also brought them in for mild dysphagia, and we used the Edinburgh dysphagia score, so those that had a score of less than 3.5. And then the second group was the Barrett surveillance. But as I've mentioned, this talk is mainly about the symptomatic patients, and that's most of what the data that's going to be presented is in relation to. When we tried to launch this, there were some concerns. We met, as all of the upper GI surgical colleagues met together, and some concerns were raised. And the first of these was that, well, some of these patients are non-specific. They don't always target just esophageal symptoms. It can be a very mixed population. And we made it clear that this was an esophageal test. This is for esophageal symptoms. It's not for gastric symptoms. And so there has to be a degree of specificity in some of the symptoms that they're complaining of. It has to be chronic reflux and, as I mentioned, low Edinburgh dysphagia score dysphagia patients. Was then a question about this being a screening tool for Barrett. So what's your follow-up plan? Well, the follow-up plan would be this requires an endoscopic diagnosis. So if we think patients have got Barrett's esophagus, we will at some point scope them. We did decide if we hadn't really started endoscopic services, then we may follow these patients up with another capsule sponge until that service started up, which at that point we had nothing else. So it seems like a reasonable thing to do. One of my colleagues in particular felt that, well, we're not actually diagnosing correctable mechanical issues, by which we're saying intrathoracic stomachs, paraesophageal hernias. And absolutely correct. There's certain patients that we're not able to actually diagnose and then correct, although surgery wasn't really happening at that point. And the way that we dealt with that was through our pathway. And part of that pathway was, if you get a negative sponge, if that patient is still symptomatic, you will follow them up. You don't discharge them at that point. So we did have an opportunity to make sure they didn't have something that we could correct. And then there was the argument about endoscopy being the gold standard. which a very good endoscopy is the gold standard, but we didn't have it at that time. So we developed this robust pathway. The key to this was to get trained upper GI staff, whether that was nursing or medical, it wasn't clear, and we felt probably the best people to use was our trained nurse endoscopists. They already had years of experience in undertaking endoscopy, they had already been vetting referrals, they already followed patients up, they sent letters out to patients, they looked at results. These were experienced nurse endoscopists. And so we trained them up not only to carry out the procedure, but also to vet the referrals and make sure they took symptom assessments at the time of undertaking the test. All the patients had pre-procedure inclusion, exclusion, and symptom assessments taken. The inclusion I've mentioned, there were a reasonable list of exclusion criteria, and so we were really honing down to safe patients with reflux-type symptoms or low-grade dysphagia. And as I mentioned, all patients had a symptom assessment at the time of the sponge, and that very much helped us dictate whether that patient could be safely discharged if they had a negative sponge, or whether if they had continued symptoms to make sure they stayed in the system and they were followed up with appropriate further investigation. The governance was a bit of a nightmare, but it happened surprisingly quickly. And there was just a lot of support in doing this while the new endoscopy services were down. We fought pretty hard not to take endoscopy services down, but it just wasn't acceptable to senior management. But the fact that we offered them an alternative was heavily supported. And again, based on Best 3 having come out, it was felt like this was the right thing to do. So our very first meeting as a group of interested clinicians was in June. We went through all the different processes, and by the 13th of August, we got final approval for us to bring in the sponge. That allowed us to start, and our first patient came into a standard clinic room in our hospital on the 14th of September 2020. It was standard PPE. This was not an aerosol generating procedure. And initially we had 2 trained nurse endoscopists that were doing this. Importantly, and from a safety point of view, we felt it was important that we had access to endoscopy 24/7, which we did in that hospital. It's an acute, very busy hospital that has a busy endoscopy department. And that gave the reassurance regarding complications or possible string detachments as to we could deal with them straight away. I mean, the only thing I would say about the 2 trained nurse endoscopists, it was where we started off, it was what we were able to do. That became later on a bit of a strain in the service when one of those nurses went on maternity leave, very closely followed by the other one. But that just meant we very quickly trained up 2, and now the other 2 are back, so we've got a pool of 4 nurse endoscopists that undertake this. And I think that's an important part if you're setting up a service, that you've got that resilience within your service. So we managed to get 1,200 patients to have a capsule sponge over the first almost 3 years, just over 2.5. And you can see that we had symptomatic, 527 of those patients were symptomatic. There were some challenges. The first one, and the one that the nurse endoscopists came back to me the most on when I asked them what they felt the challenges were, was patient awareness and their acceptance. Patients were anxious. They didn't really know what swallowing a capsule would be like. And they weren't really sure if this was okay to do when they thought they should be having a scope. I think through really good communication from the nurse endoscopists that they managed to get patients through that first capsule, and any patient that had to come back for a second capsule had no fear whatsoever. They knew it was a fine procedure. They had no concerns about it. In terms of does this pick up as much of the scope, explaining to the patients there wasn't an alternative, but we knew that this was very good at sampling the esophagus. Most of them were okay with that. And again, once they went through the pathway and came out the other side, our satisfaction scores were very similar to elsewhere. I think the nursing team found it difficult initially to get the right group selected for this procedure, and as you would expect in any service that you start, that can be problematic. But having done it over and over again, they are now very versed in what's the inclusion and exclusion criteria and are much more confident. Kind of practical things, there was some difficulty managing stock levels. You do need to have management on your side signing off orders in time, and there were a few times when our stock went really low. In fact, I think there was one point where we didn't have any stock at all and we had to stop for a few weeks. And as it's mentioned, we did have to cancel some clinics. And then capacity issues, as we've continued to do this, we've had more capsule clinics running than we have got capacity for in our hospital. But there are 3 acute hospitals in Lanarkshire, so we've managed to get clinic space in Monklands and Hairmyres, and we're running them across all 3 sites now. And because it just requires a clinic room and doesn't require an endoscopy suite, that's a very easy thing to do. We ran into a few problems. The first of them was that we had a few sponges detach from the string. In fact, we became the UK centre of string detachment, which wasn't great. However, we retrieved them all endoscopically. They were pulled out, and because they were pulled out through the esophagus, we still sent them off for analysis. Eventually, it was probably a technology issue, and so we have switched to a different capsule sponge, and that was towards the end of 2023. Since that time, there have been no string detachments, and having spoken to the nurse endoscopists who do that, they do feel like this is a much more robust sponge that we use. They're much happier with it. It doesn't feel quite as flimsy or as fragile as the previous one. So I think we've managed to deal with that potential problem. The second one was not one that we saw, but the Scottish Government asked the Scottish Health Technology Group to come out with a report about capsule sponge, because it came in for good reason, but it hadn't had the same kind of reports that most other technologies that are brought in had had. And the remit was to evaluate capsule sponge for the detection of Barrett's and early cancer, that very specific remit. So they used the studies that were out there and had a pooled estimate of diagnostic accuracy was that the sensitivity was 82% and specificity was 91%. And the way that they reported that was that 19% were wrongly told that they didn't have Barrett's, and that 9% were diagnosed with Barrett's when they didn't have it. I think from that side, we did say we would scope these patients, so we would ultimately come to a correct diagnosis. And I think that was misleading. The other thing was that when they looked at a cross-sectional study diagnosing dysplasia, again, the sensitivity and specificity, they reported that as 11% were wrongly told that they did not have dysplasia or esophageal cancer. And for whatever reason, and I don't know if it was directly related to this, the Scottish Government, who had led this with a programme and had been funding all of this, said as we go into the end of the financial year, April 2024, we're not going to fund this anymore, and they gave it back to the boards to decide what we were going to do. And then we got into an area where we had to kind of make an argument to our boards. This is something we want to continue to do. And this was a couple of the reasons that we managed to persuade them. So the first one was there are studies out there that show endoscopy is not very good for diagnosing early cancer. So a population-based study of over 20,000 patients show that early cancer is missed in 23% of endoscopies, which is worse than what was reported in the Health Technologies Group publication. And then again, a systematic review and a meta-analysis of over 140,000 patients showed that early cancer was missed in 21%, and early cancer and high-grade dysplasia in 26% of endoscopies. Not only that, we were then able to audit our own results, and we audited them with this being the waiting times at that point. And that was if you were referred in for an urgent suspicion of cancer endoscopy, you had to wait 4 to 6 weeks. If you weren't a suspicion of cancer but felt to be urgent, you were waiting half a year. And if you were routine, you were waiting over a year at that point, which was concerning. And not only that, we showed that we could improve their volume capacity issue. And this is of the analysis of the 527 patients we had who were symptomatic. We managed to discharge 74% because they had a negative sponge and they were asymptomatic by the end of that pathway. 26% went to endoscopy, but you can see that we could discharge a large number of patients. So that problem went away, and our board agreed to continue to fund us to do this. Since that time, a number of publications have come out to further support the work with chronic reflux. The first one that I've mentioned here is the work by Siobhan Chen, who is from Scotland, and she brought together all of the data from the 11 health boards that had taken on the capsule sponge, which was over a 32-month period. Nearly 80% were negative biomarkers, and that allowed 70% to be discharged. 27% went to endoscopy, and that was based on either symptoms or results. In addition, they looked at those patients that had an endoscopy after having had a sponge, and intestinal metaplasia was diagnosed in 16% of patients that had an endoscopy in the follow-up period, and in those 88.5% were biomarker positive. So that continued to show that it was a sensitive marker. There were 10 patients who had intestinal metaplasia or malignancy that were sponge negative, completely negative. And there was one patient that was diagnosed 27 months later that had an esophageal cancer. That is a patient from Lanarkshire, and I know their story. I actually know their story because the patient's under me. And there were issues in terms of them getting an endoscopy because that had always been the plan after their initial sponge. The patient had a lot of hesitancy, wanted to speak to people first, and then was put into that system where there was that delay to get the urgent scope. However, they were diagnosed with an early cancer and they were a resectionable candidate. Unfortunately, their fitness would not allow it. But they didn't come in with advanced disease. They were still diagnosed with potentially curative disease. There were also 3 gastric cancers, and I think the importance of that being raised is the fact that their symptoms, when you look at them, were maybe not all esophageal. And that's why that robust pathway is really, really important. If you've got patients with gastric symptoms or non-esophageal symptoms, this is not the route for them to go down. They should not be getting a sponge. I think the other thing to say is if you look at the Pugic data, this is not anything like as bad as that data. Okay, and then this is another publication that was a national multi-centre prospective cohort analysis, including 22 centres in NHS England, over 2,000 patients. And again, there was no adverse events in this population. 78% were discharged and 22% underwent endoscopy. So this has given us reassurance that it continues to be the right thing for us to do. And there's a further reason why that's the case, and I'll go into that in a second. Now we've got our full data analysis. So our total number of patients since September 2020 is 1,065, and these are the reflux patients. So these are the symptomatic patients, not the Barrett's. 77% have had negative biomarkers, 71% have been discharged, and 28% have gone to endoscopy depending on the results and their symptoms. This is just data analysis that I've done. It's not published as yet, and the reason for that is we'd like to do some further follow-up just to know that this, in terms of have there been any dysplasia, what happened to those patients, has there been any other cancers? And this is when I was saying we still feel it's the right thing to do. This is why we still think it's the right thing to do. So this is, as of this week, the situation in NHS Lanarkshire. And that is that we've got 550 patients that are waiting over 6 weeks for a scope. If you're urgent suspicion of cancer, you're still 4 to 6 weeks to come into a system. If you're urgent, you're 30 weeks. I don't know why that's got worse rather than better. And if you're routine, it's 36 weeks. So we are bringing down the routine. And from what I'm told about repeats, we're bringing that down as well. So we're making some gains, but we're still not in a great situation. And so what we've now done is we have brought capsule sponge into our boards. So I have to say it's our boards, it's not a Scottish-wide policy, but we've brought capsule sponge into our referral pathway. I don't know, I assume ACRT exists in NHS England as well, it does in Scotland, but this is active clinical referral triage. And this is where a senior decision maker is to make a decision where patients should be triaged to. We have decided to do that because we don't really have the capacity within our consultant allocation, and because there appears to be no additional funding despite we've been asked to do this. We are again using our senior nurse endoscopists to do this pathway. 3 of the pathways are defined pathways. They're objective. You can't go wrong on them. One is the urgent suspicion of cancer, and if you're urgent suspicion of cancer, you're getting a scope, or you're getting a scan, or you're getting whatever it is you need to do. There has been a recent launch from the Scottish Government with this new pathway. They launched it at the end of last year, and I have to say they've set the bar in a really worrying place. You really have to have really concerning or probably advanced symptoms before you can get referred into that pathway. So that leads to 2 other pathways, which are the dysphagia and the reflux pathway, which again, there are Scottish Government pathways. However, most of the patients will go down an urgent or probably a routine route. And as you can see from the previous slide, that is a significant wait until they get an endoscopy. And so we've put a sponge at the front of that pathway for patients that are in routine or urgent. We are doing it for reflux. We have decided to do it for those with a dysphagia score of less than 3.5, but that comes with a symptom assessment. And if they've got any previous history of a stricture, if we've got concern about the way they're describing the dysphagia, we will take them out of that pathway. But we still feel that's better than them waiting 6 months or more to get their scope. We're auditing this. We only started in March this year, but that is our current pathway. So I think, in summary, our volume of referrals are greater than our scope capacity. This is something we now have a good evidence base that hopefully will allow us to identify patients that have Barrett's esophagus and allow us to start hopefully, again, if we can get the dysplasia analysis, early cancer, bringing the patients in for endoscopy sooner when they need it. So from our point of view, this is an important part of our pathway, and we plan to continue it. Who knows what the future holds, but we'll do further data analysis and longer term follow-up. And it's hard to see the service improving the way the referrals are coming in at the moment. Thank you very much.
Thank you, Gavin. That's fantastic. Taking us through your journey, which sounds like it was quite painful at times. We've got a few questions that are come through on the app, and then if people have got other ones, stick your paws up. There's another question here, probably might be for me, I don't know. It was about how soon can a detached capsule be removed? Well, as soon as you can arrange an endoscopy, but it's not that critical. I don't know what was the gap between your sponges coming off and getting a scope retrieval going?
I mean, we had 24/7 endoscopy. There was an on-call consultant. Our surgeons do the emergency endoscopy, and we've got a 24/7 service. So these patients were just brought up to endoscopy. We've also got brilliant endoscopy nurses who will find the space and squeeze it in. So most of these patients had their scope within a few hours. It's of a reasonable size. The actual sponge itself, I mean, I don't think we've ever looked. I don't think anyone's done a study of how long it takes and can it leave the stomach. But we certainly had them in within 4 to 6 hours.
Yeah, we haven't had any go through to the small bowel. Danielle.
Just to follow up now, because I think we're the English version of the top detached capsules in the country. We had two detachments back in the early days before Endosign, and ours were removed very simply within a few hours. And I would say, compared with most of the things that gastroenterologists have to remove from the stomach, removing a soft sponge with a snare or a Rothnet it's not difficult. And none of our patients had any long-term sequelae or anything like that. So from a reassurance point of view, but we've now done nearly 3,000, and I think we haven't had a single detachment since we switched.
That's an important thing, because everyone is nervous about this. What happens if this? But actually, since Endosign was developed, it hasn't happened. Of course, there's always a chance it might, but it's not the disaster that everybody thinks it might be. I've got another question on the app. Can a person with reflux symptoms and abdominal pain have a capsule sponge test? How would you manage that, Gavin?
So they would go down 2 pathways. If they've got reflux, I would still sponge them because they wait for the endoscopy. But I would also see them in a clinic, and depending on what associated symptoms they had, they may be seen urgently in a clinic. So that's not a simple capsule discharge by any means. Abdominal pain that's not a indication for this test. I think there's lots of criteria in our suspicion of cancer guidelines in terms of the reflux and the dysphagia guidelines as well. So you're going to need more information from that patient. They may even get a triage phone call. It's a wee bit more complex. But if they had reflux and separate abdominal pain, that's 2 different pathways for us.
Another question on the app. Have you picked up any patients with EOE in your reflux cohort capsule sponge?
There has been. I don't know how many, and it's tiny, but there's definitely
a handful.
It's a handful. It's a small pickup.
Do you want to say anything about that, Danielle? Because I know you've got an interest in capsule sponge and EOE.
We have picked up a few, but the problem is that in its current form, when they look at the sponge looking for Barrett's, you don't automatically look for EOE in a systematic way. So it's not currently a good test if you're suspicious of EOE. Although we have done a study which we're just submitting for publication, which has shown it's very accurate for follow-up of patients with EOE.
So not for diagnosis, but probably for monitoring response to therapy. And that could be a big game changer for that large pediatric population, the teenagers with EOE who keep having to come up for endoscopies, which is pretty miserable for them. Any other questions?
Just one at the back.
One at the back? Didn't see. Yeah, there's a hand waving.
Sorry, this is sort of off the back of the gastric cancer question. At the point of triage, I'll just say it as well. I'm not medical, so I might need a bit of help with this. At the point of triage for capsule sponge, what signs should we look out for to send someone down a gastric cancer path more so rather than down a path for capsule sponge to look at Barrett's?
So these are patients with external symptoms. If you've got epigastric dyspepsia, abdominal pain, they're all non-esophageal symptoms.
Mm-hmm.
So not being medical, does that make any sense to you? Retrosternal,
Yes.
epigastric? Yes.
Yes, thank
Great,
you.
good. Just checking.
I'm a clinical scientist, but
that's fine.
We're not. We're all benign, so.
Okay.
Yeah.
Just checking.
Yeah.
So it's anything we consider. So patients with so again, if it's not true dysphagia, if they've got dinophagia, if they've got chronic reflux, if they've got retrosternal burning, all the esophageal symptoms that you would read about.
Mm-hmm.
So anything in about here, then they're considered esophageal.
Yeah.
There are some symptoms where we would consider them red flags and we wouldn't do it. So if they actually had true dysphagia, if they had a high Edinburgh dysphagia score, or they had any previous pathology that we were concerned might cause problems with the sponge coming up.
Would early satiety be a sign for gastric cancer, perhaps?
With what, sorry?
Early satiety, you're getting full quickly.
Yeah, and we wouldn't sponge a patient with early satiety.
Okay.
It's a very bad symptom. Yeah, early satiety. Right, we're running out of time, so I think I'll call the session to an end. I expect Gavin will be happy to answer any other questions on the way out. But thank you for attending. Please do rate the session. And thank you, Gavin, for your excellent talk.
Thank you.